This is an educational video on a dorsal scapular nerve entrapment. I cover the following: the function of the nerve, where entrapments occur, why entrapments occur, clinical signs of an entrapment, and how to effectively treat it. For those of you who don't know me, my name is Dr. Matt Maggio, and I'm a non-surgical expert in chronic pain treatment. My focus is on finding and fixing nerves that become stuck to muscles with a glue-like substance that's called adhesion, also known as scar tissue, and reducing inflammation from chronic pain naturally without the use of medications or injections. This results in a significant increase in flexibility, function, and long-lasting pain relief. I'm also the creator of the Peak Method, where we teach overworked massage therapists a new treatment system that cuts session times in half and eliminates the frustration of inconsistent results so they can avoid burnout and help more people get out of pain. All right, so dorsal scapular nerve entrapment, whenever I make videos about this, they tend to be the most popular because I think every human in the planet is living with some type of pain in this area. So I'm going to go over symptoms, palpation, and successful treatment process. So what's the function of the dorsal scapular nerve? This nerve provides the motor input for the levator scapulae, the rhomboid major and minor. It also helps these muscles to basically elevate and retract the shoulder blade. So where does it get stuck? So first off, we always want to talk about like why nerve entrapments happen in the first place. So nerves are built with extra slack, with about 15% of extra slack to kind of make them able to move through the muscles and get where they need to go. But over time, adhesion builds up in and around the muscles where the nerve goes through, and then eventually it does get stuck there. So a lot of times when you have a patient come in, they're going to be complaining more clinically of like in between the shoulder blade as in there as well. And a lot of people tend to think it's more of like a rhomboid problem, but more than likely the dorsal scapular nerve is getting compromised further up in the chain. And the reason they're feeling most of it down here is because that's where most of the pulling is happening. It's almost like they're getting stuck high up and then it's pulling through here. So the real common areas where you're going to find most of it is definitely going to be as it pierces through the levator scap in through there. There's going to be a lot in there. A lot of people think that's just like a knot or a trigger point in the muscle. What it is actually a nerve entrapment, and nerve entrapments have to be treated a little differently than like a common trigger point. And the other area where it does get caught is between the C4 and C5 nerve roots. So the way that the nerves come out, whatever is the listed bottom one is the nerve root there. So what actually innervates the dorsal scapular nerve is the C5 nerve root. And a lot of times it gets stuck in between the scalenes. When it comes out, a lot of times you're going to see it either get caught between the middle scalene and the anterior scalene or the posterior and middle scalene a lot. So it gets caught through there, and then you're feeling a lot of that tension further down as you go. So why does it get stuck? I said before, poor and sustained posture. People just spend way too much time sitting, looking down. Muscles don't get enough blood flow and oxygen. They start to lay down all of that adhesion, that scar tissue, and then it gets in there. Sometimes with injury or trauma, maybe past accidents and things like that, or maybe even some issues from past surgeries where it created a lot more adhesion, a lot more scar tissue. Probably 90% of what we're going to see in our practice and what you'll probably see as a manual provider is going to be those people where there wasn't a lot of trauma or injuries. It's just gradual buildup. That's like 90% of what you're going to see each time. And adhesion is very real. Don't let anyone on the internet tell you that it's not. Don't let some jackwagon physical therapist chat GPT you a whole novel into one of your posts and say, hey, treating adhesion doesn't work. The science is done. They're full of it. It's real. Things are stuck. Use your hands. You're a manual therapist. So some common injuries associated with an entrapment of the dorsal scapular nerve. One is going to be dorsal scapular nerve syndrome. I don't like that one because anything with syndrome in it is just a code word for they really have no idea as to what the hell is going on. Definitely chronic upper thoracic pain into that area. Might see some postural distortions of the thoracic spine too. A lot of times when there's a nerve entrapment, the shoulder might roll forward and drop down to unload that area because the body doesn't want the nerve to get more compromised than it already is. And then definitely chronic neck and shoulder pain as well. So how to find it? Palpation is really key in this area. You want to slow down and find it. So I always like to find what I call really big bony landmarks. One is going to be the C7 spinous, and then the other one's going to be the medial border of the shoulder and the superior angle. And I'm going to kind of check it all through there as well and seeing where it's getting jammed up or getting caught. Usually when it's a nerve entrapment, it's very focused and it almost feels like it's precise in that area, and it it's small, like not the whole area is loaded up. It's just that one area. It almost feels like a piece of like string that is stuck to like a piece of bubble gum under there. When I do palpate it, I do like to have the client sitting, and I actually have them pull their arm over and down. That actually tensions the rhomboid in a little bit and the levator as well. I like to palpate things at end range tension because it really allows that nerve entrapment to pop up so I can see it. And then if I want to get a little more advanced tension, I'll drop their head down and then I'll actually tilt them away. So if I'm working the right side, I'll drop them down and tilt them away to the left. That'll load that levator up to that nerve root as well. So I can really palpate and see where that tension is coming. I don't like to palpate it under slack because it's a little more loose. It's harder to find. So I do like to palpate it under like the most amount of tension possible. So how to effectively treat it? First is you want to go slow, precise, and focused. You do not want to be in a rush to do this. And what I like to do is actually start a little bit higher. So I'll start up at the C4, C5 nerve roots, going in there and cleaning that up, getting proper depth, proper tension in the area as well, because you got to clean that up first because that's where it's getting caught the most, and then it's going to work our way down. Then we'll go down to the levator, catch it through the levator as well, then at the rhomboids as well. We always want to, like I say, have proper depth, then tension, and then feel the tissue slide. This is not pin and stretch. This isn't myofascial release. It's very focused. And what I tend to find is like a lot of providers, they go in there and they're way too compressive and they jam on the nerve. It hurts like hell for the client. You think you're doing something because it hurts, but you're not actually doing anything. You're just really making the area more inflamed and angry. It temporarily feels better because it relaxes everything, but that problem is going to come back right away. Again, I always say nerve entrapments are like the Goldilocks. You want to get just the right amount of depth, just the right amount of tension. And what I usually do is I just start with just the head going down first as we're doing the motion in the treatment. And if it's not generating enough tension on the area from what I'm feeling, then I will rotate the head away at the end or laterally flex it. And the key here is when you find those palpable adhesions, like say you find it in the nerve roots at C4, C5, you also find it at the levator scap and maybe also in the rhomboid. I'm never doing more than like 3 to 5 treatment passes on that. You know, you don't want to hammer away on this area. People make this mistake and they think treatment can either make the problem better or not change anything at all. They don't understand that if you actually overtreat it, you can kind of anger the nerve, create more inflammation, more problems down the road. You know, treatment is like a medication. You want to give enough to be effective, but you don't want to overtreat because you can make it a lot worse. So I always err on the side of caution, especially with nerve entrapments, is less is better. I'm going to slow down, reset every time. I'm not in a rush. I'm going to be very detailed, precise, and focused. That's all I got in the video. Appreciate you watching. If you got anything out of it, you know, share some insights in the comment sections below. I try to interact and share information with people out there that are generally, you know, want to learn and want to get better and just get better treatment skills and better results for their clients. You can also share this with other providers that you know might help, you know, spread the word, share it around. You know, we're really getting to the path of like actually solving problems and fixing problems. And lastly, if you like what I'm teaching, you like what I'm sharing, you want to learn more, you want to get a better idea of my system and the process that we do, you can go download our free training modules. These links are available wherever you're consuming this. We take you through the entire process from start to finish, like taking a history, understanding what's going on, advanced palpation, advanced treatment, functional based tests, client education, everything you can think of to really allow you to get out of this path. I always say so many people are stuck in this model of like being what I call a service provider instead being a solution provider that gets the reputation in the area of someone that can truly fix problems that other people can't. And after that, you're going to be the best of the best. Appreciate you watching. I'll catch you on the next one. Bye.